So I want to thank you all for your engagement, and just to let you know that we definitely feel that reciprocal motivation to keep the field moving forward, because there's nothing worse than coming to an event like this and having nothing to say about new developments. So I will barrage you with new developments today, and I don't want to overdo it. There's a lot of sciencey slides here. I don't really mean to pummel you with them, but it's actually good that they're there, and I'll try to navigate them from a layperson's perspective so that you understand with each of the things I'm going to talk about today, what it means for patients, caregivers, what's on the horizon. All right, so it's been a very active 5 to 10 years in appendix cancer. It felt for a long time like nothing was really changing, and all of a sudden there's new things coming out of the sky left and right. I'm going to talk about a few of the things that we're involved with, that I'm involved with personally, and some other things that I don't have much experience with, so I'll just let you know. Have free-floating mucin, and in a situation like that, it would be really great, actually. So everybody's different, but as you get later into a disease process where the pockets of mucin aren't free-floating because there's been surgery and treatment and they're kind of walled-off areas, those that we can get into with a needle, something like this would be very helpful. It's just that many of them you can't get a needle into, or it can be dangerous. So we'll see which way this goes. Obviously, if there are emerging reports that this is beneficial, I'm sure many of us will pick it up as soon as possible. All right, and then I'm going to talk about immunotherapy for peritoneal surface tumors. And this is not a new concept, but meaning you can go back into the literature and look as far back as the 90s, certainly the early 90s and mid 90s, for evidence of treatment with cytokines like IL-2, but that was ancient history in immunology. So much progress in immunology over the past 20 years and immunotherapy that I think peritoneal surface malignancy sort of just fell off the radar, and things like breast cancer and colon cancer and lung cancer, huge gains in survival and outcomes. So I think it's time now to refocus our energy on applying that in peritoneal surface, taking the advances that have been made in many of the major tumors. So we have a couple of protocols that have been open and accruing, looking at trying to number one, understand, and number two, change the peritoneal immune environment to try to help get an immune response to tumors in the peritoneum. And so I'm going to show you a couple of examples of that, but you have to think about the peritoneal cavity as sort of a few different things. Number one, it's the organs. Number two, there's tumors. Those are the obvious parts, but there's also the background peritoneum. So we think about cancer as, sometimes people call it a seed in soil for a metastatic cancer growing. The seed is the cancer cell coming from wherever the cancer started. The soil is the place where it lands, and then it's got to grow. And what is it about that background peritoneum that either invites or allows the tumor cell to begin to grow? And then also we need to think about the peritoneal fluid. So there's going to be sort of a continuum between the normal peritoneal environment to the environment where there's tumors growing on the peritoneal lining, to where we get to an advanced situation where there's also standing fluid or ascites in the abdominal cavity. So we've taken an approach to look at all of that, but mostly the fluid and the background peritoneum. This was from a study that was published, I think, last year, just looking at the immune system chemicals, or we call them cytokines, but they're like hormones for the immune system, and they definitely influence the way the immune system behaves, particularly as it relates to a response to cancer. So the right cytokines can ramp up the immune system to recognize and attack a cancer, but the wrong cytokines can completely shut that process down and can allow a cancer to grow undetected by the immune system. If a cancer is growing, it means the immune system is asleep at the switch. That's the bottom line. It has to be. Otherwise, the immune system will recognize an abnormal cell, and it will never grow into a tumor. So by definition, any tumor that's big enough for you to see, the immune system is asleep at the switch. So the idea really is to wake it up. and to understand what are the ways that either the cancer itself is turning off the immune system, or the circumstances, inflammation, and other factors might be turning off the immune system, and try to swing the odds. So one of the chemicals that we found that was in very high concentration in orange, which is patients that have carcinomatosis, the fluid from the abdomen, the peritoneal fluid, versus patients that didn't have carcinomatosis, was IL-6, which is an interleukin or a cytokine. And it's kind of a generic cytokine that sets off a lot of processes in the immune system. And there is a number of specific blockers for this pathway, one of which is called tocilizumab. And tocilizumab is a blocker of IL-6, and it has a lot of experience being used with in patients with autoimmune diseases like rheumatoid arthritis. It was also used to treat patients with severe, overwhelming COVID responses because it kind of shuts down the cytokine release or the massive, overwhelming toxic consequences of COVID that really weren't in the lungs, but it's kind of created a lot of deaths from COVID from almost an overreaction to what was happening in the lungs from the immune system. So the bottom line is there's a drug at this pathway that has been used in many, many patients for a couple different reasons. And we wrote a clinical trial to use this drug, which is actually still accruing now, to use this drug as an injection either into the pleural fluid of patients with pleural metastases or into the ascites fluid of patients with carcinomatosis. And so we're still fairly early on. This is a phase 1 study, so it's only going to be 12 patients, and we're early in the accrual process here. But the goal is to prove that it's safe, number one, to inject tocilizumab into the body cavities. It's only possible right now to treat patients that have ascites that we can get a drain or a needle into. But assuming that is safely completed, by the way, we're also measuring all the effects at each time point. We take the fluid back out of the after the treatment and take it to the lab and study all of the impact on the immune cells and all of the cytokines or the immune system hormones that I talked about to make sure that we understand what's happening and whether the drug is having the desired effect. Anyways, once we are able to prove that it's safe to do this, then we can roll out bigger studies where we can hopefully not have to put a catheter in, and we can either just do a subcutaneous injection, which is what patients get for arthritis, a monthly injection under the skin, or a one-time shot into the ascites, but not have to have an indwelling drain there for it. So that's on the horizon, and hopefully we'll see a response there. And then one last study that we did, and this goes back to the concept of thinking about the peritoneal lining, the background lining, and the immune environment there. And this was a clinical trial that was completed now, which we called RIOT-1, which was taking an immune stimulant, and I'll tell you a little bit more about that, but an immune stimulant in patients that were having a laparoscopy and injecting that into a tumor, and then picking a different tumor and injecting it with saline, just the control, the carrier. And we did this in patients that were having a laparoscopy before a bigger surgery. So this is very familiar to you all, but a laparoscopy to see if a bigger surgery is possible. And then we plan to do the bigger surgery a week or two later, usually 2 weeks or so. So when you have a situation like that, where you're going to be in the operating room twice for regular purposes, that is a golden opportunity for clinical trials, because you can do a treatment at the first event, and then you can go get the tumor 2 weeks later and see what happened. Very few other scenarios that are like that for us. So we call it a window of opportunity trial, because it really gives you a chance to see early on, as opposed to giving a treatment and then waiting 3 months and getting a CAT scan, and you're not going to know for years whether something like that has worked. So this gives us a signal almost not instantly, but within 2 weeks or so. So this was done in 12 patients. The actual chemical that we used was nothing fancy. It's actually a component of E. coli bacteria, which are everywhere, but there's a cell wall component of E. coli that when the immune system is exposed to it, it's a signal that there's a problem. There's an infection, potentially an infection. So again, to go back to the concept that tumors have evaded the immune system, or else they wouldn't be there. So you have to, I think of it as you have to start a fire in the tumor to get some smoke to get the firefighters to come, right? They don't know there's a problem. And so this chemical is one way, and it's not the only way, but it is one way of sending a signal to the immune system that there's a problem and it's right here, and hopefully there's some recognition and a response. And the way that we look for a response is to take those tumors out, and we compare before and after. We take a biopsy at the first go, right before we inject the medication. I don't call it a medication. We should just call it a chemical. It's an experimental agent. Right before, and then 2 weeks later after, we can look at all the cell types and all the chemicals in those two samples to say, okay, before it looked like this, now it looks like this. And then also we have the saline injected tumor as a control. So we can say that this didn't happen when it was just saline. It only happened when we gave the drug. So this is a picture of a tumor being injected. You can see on the left side, this whitish blob here is a peritoneal tumor. That's intestine. This is mesentery. And this is a laparoscopic needle. And with the tip of the needle right in the tumor, we just injected the agent, which is called lipopolysaccharide or LPS, into the tumor. And then on the right side, just to show the method, those were other tumors that we injected, and we just threw some sutures next to this so we could recognize where we worked. And when we go back 2 weeks later, we need to remember. A lot happens in 2 weeks. And so we don't always remember where so we had to mark them carefully so we knew which one was which. And that is where that stands now. We have all 48 tumors from 12 patients that are in the lab. We've done some preliminary testing and shown that some of the cell types went way up in the lipopolysaccharide injection group that didn't go up in the saline group. That's a first stab at it. We have a lot more work to do to slice and dice all of the immunologic variables. That's a really great question. The spleen is really thought of as a monitor or filter of what's happening in the blood, not so much in tissues. So you think of, at least I think of, this is simplistic. I think about the spleen as sort of the lymph node of the bloodstream. And an immunologist would probably be very offended if I said that, but that's the way we think of it, is that it's doing something for the circulating blood, but not for the tissues necessarily. And just like if you remove a lymph node from the area of the colon's still going to be fine, and there are other lymph nodes. We remove spleens, very commonly, and there's no noticeable effect that you can measure. There is a higher incidence of some very, very rare infections that we don't even know if is actually real. But because of that, we have just come to the practice of doing immunizations for patients with splenectomies. But we don't know if it will have an effect here. That's something we have to look at backwards. We did not kind of pick patients that did or did not have a spleen. It's like getting a PPD, where I don't know if you've had a tuberculosis test where you just get a very small injection right under your skin, and if it gets inflamed, it means you've been exposed, and if it doesn't, you have it. So it's a very local effect, if anything, and so we didn't really see any side effects from that. All right, so I think that's plenty to talk about. I'm going to leave up some time. I have time for questions or commentary, or yes.
Yeah, so is immunotherapy always, it's not necessarily directly trying to change what the immune system is doing? Is it that it's sending up a stronger smoke signal in hopes that the immune system comes on board to do what it's meant to do? Is that right? And is that true?
Sort of. It's a great question. So the question is immunotherapy always that? Immunotherapy is many things. So this is an intratumoral injection is one form of immunotherapy, but it's not the only form, and it's not even the most commonly used form. These days, the most commonly used form is immune checkpoint inhibition, and that is one of several ways. So let me just take a step back. In order for the immune system to recognize and kill a cancer cell, there's about 100 steps in that process, and some of them are very critical steps and others are not as important. And a lot of them are very redundant, meaning that, for example, there are things called immune checkpoints, which if a T cell or an immune cell goes to kill a cancer cell, there can be a signal back, don't kill signal. And then you have to add up all the don't kill signals and all the kill signals. And that's that sort of equilibrium that happens in every interaction between an immune cell and a normal cell. And so that don't kill signal gets ramped up in cancer cells. They get mutated in a way. That's one of the ways that cancers have developed to avoid destruction by the immune system. And those checkpoint inhibitors block the don't kill signal. And it swings the balance in favor of the lymphocyte or the T cell, the immune cell killing the cancer cell. So that's the most common single agent. But there are many other forms of immunotherapy, including cell therapy and CAR T cells, and just giving cytokines in some cases, the chemicals that I was talking about, the hormones. You can just inject those into the body. That's not well tolerated. That's 1990s medicine, but that's where immunotherapy started. But it's evolved in 100 different directions since then. So this is one of the things along that 100-step path that I said that needs to happen is a signal to the immune system. There's actually several different signals that need to go up simultaneously to tip the scale, but it's a tipping of the scales is the way that we sort of think about it. So in an ideal world, a trial like the one that we did will be followed up by a trial where you inject the tumor and then you give a checkpoint inhibitor to the same person. And so you tell the immune system where the problem is and then take the brakes off and try to get it to work, in tandem. So probably in the future, these will be combination regimens where you have several different things happening at the same time. Another example is and this will be a study that we'll be doing at Allegheny, which is to take T cells, immune cells out of the peritoneal fluid. And when we do that and study them, they're all exhausted or it's actually a term, exhausted T cells or the regulatory cells or what have you. But they're in an environment where they're swimming in a pool that's full of signals to go to sleep or to ignore the tumor over there, right? So we need to study what's in that fluid and then change it out. Either empty the fluid and put different fluid in is probably what we'll end up with some of these agents like tocilizumab or something else as a conditioning regimen, and then put the T cells back in, now all juiced up and ready to go, right? Like a high school football team, right? Like you just have to put them in there and give them Red Bull. It's a different model that what they're swimming in now is putting them to sleep.
Yeah, because that was then my question is like, we're just setting up a strong signal, but then in the immune cell, they're exhausted because the majority of people at this point have had chemo, have had stress, high stress. Their immune system is already just very low level functioning.
Very unlikely that this alone will make that much of a difference, and yet we can already see under the microscope that something is happening there. So I have no expectation that we're going to be marketing E. coli, LPS as a drug anytime soon. It's just the concept that the smoke plus something else plus maybe T cells, each one of these has to be proven safe on its own before the FDA will let you start using combination regimens in patients. So it's a really frustrating, slow process in some ways.
Can you make your slideshow available for us to look at? So if we were interested in looking further at the studies you referenced or looking closely at the graphs that were up on the screen, we can look at them.
Just to know that some of those are mine and some of them I tried to attribute them with the references at the bottom. Hopefully I remembered all of them, but everything that I used here is available publicly. So we can make the slides available. Yeah.
I had a quick question as we've been discussing it. It seems like there's more and more people finding their way to like the appendix cancer groups and stuff. And is it, it's kind of concerning, but is it more you're able to diagnose it better than in the past, or is there a rise in this type of cancer?
Yeah, so there's probably both. Probably both. Increased recognition, increased communication from, and just in the internet and from patients to one another. There's probably a rise in incidence as well. There seems to be, but it's always hard to know how much of that is just due to physicians becoming more aware of appendix cancer being different than colon. Things that are appendix cancer now might have been happening in the past and just called something else. Lots of appendix cancer patients come to us after going to a GYN first because it's thought to be, so it's always hard to know how much of that is just improved recognition and improved diagnosis versus a true rise. But also the population's growing, and it's just, I think there's factors that are driving it up.
And nor aware that there's such a trend in what conversation essentially like word of mouth and the ambulance are starting to follow, okay, when to stop. And they for
I think that's true also, yeah. Oh, just to say that there's increased knowledge among medical professionals that these are distinct diseases and that there's a subspecialty dedicated to peritoneal surface malignancy, whereas before, you look at a CAT scan and see peritoneal disease doesn't really, from the old school mentality, this is stage 4 disease. You don't need to be referred to somebody especially for this. So I think there's definitely a mentality, oh, I should refer this person out because things can be done for this patient. That is a big switch that took a long time. Did you have a question?
Yeah, I think a couple of years ago you mentioned in a talk about viral therapy, like targeting and infecting and destroying cancer cells. Is that something that's gotten any more traction, like with peritoneal malignancies, to approach it like using genetically modified viruses?
Yeah, that's definitely on the horizon. So we have a trial that's still in regulatory. Years later, I know it's but we're hopeful. We should be in the last steps of that with the FDA. If that's true, we could have a trial open early next year, but it's all just kind of hung up on regulatory issues.
So with that, would it work for?
That's okay. The question was about viral therapies for peritoneal disease and whether that's on the horizon.
In the type of like for PMP patients.
Yeah.
Is it a cancer cell that would be recognized the same way other cancer cells would be recognized with viral therapy? Like,
Yeah.
Is it malignant the same way that you'd be able to identify it?
So the question is, would with PMP, because it's a unique disease, would viruses that are targeted at cancer cells attack those cells? And the answer, as I understand it, is there are some viruses, like one of the vectors that we work with that generically infect cancer cells. I don't have on the top of my awareness that studies have been done with that virus in low-grade appendix tumors or PMP cells. So I don't know the answer to that question.
Thank you.
tumor.
So the question is about the difference between mucin and the mucin and the tumors and the cells and how Bromac fits into that. So the mucin comes. So think about, this is the way I think about it. You have the digestive tract right now. There are cells in your digestive tract that secrete mucin into the digestive tract all day and all night, every day. And the reason that is the case is so that when food and things pass through your digestive tract, that they glide through and go all the way through. And so that's normal. Those cells are pointed towards what we call the lumen, which is the inside of the intestine, and a lot of that mucin gets reabsorbed by your body, and some of it passes through. When those cells get outside of the intestines, they're no longer pointing the mucin apparatus, the mucin secretion into the intestines. They're pointing it wherever, which means that, if the cell gets out of the intestines and is in the peritoneal cavity, it's just randomly making mucin. And in a person who has never had surgery before, that mucin will just accumulate and they'll be free floating. And if you were to do surgery, you would open up and you can just lift it out. You turn the patient upside down and shake them, and all the mucin's going to come out, right? After an operation or two, that starts to form pockets or areas where scar tissue forms around it. And then you've got a kind of a defined pocket that has a lining, and the cancer cells are in there and they're making mucin. So they are swimming in their own mucin is the bottom line. So if you look on a CAT scan, you're going to see a glob. What you're going to see is mostly mucin, but the cells are in it or they're around the rim and they're shooting mucin into this cavity. The cancer cells are swimming in their own mucin. Now, non-mucinous tumors, on the other hand, aren't like, so if you see a non-mucinous tumor on a CAT scan, it's mostly tumor cells or the connective tissue in it. So the idea for Bromac really is to get the mucin out of the way so you can get to the cancer cells, or at least just to dissolve the mucin to make you feel better if you have a lot of tension.
So could you have mucin buildup that's not cancerous?
Yeah, there are benign reasons that this will happen. A mucosal of the appendix, which is not a tumor, is just an accumulating area of mucin that, for whatever reason, is not in the appendix, and that is not a tumor. That's just mucin. I can think of other examples, but they don't always go hand in hand.
Among all the very, very interesting and exciting prospects in the future, next on the horizon that is sort of something that may be our first line of something new.
Of all of the things that are there, probably the thing that is is closest to patients would be the very first thing that I showed, which is targeted therapies that are already FDA approved for, in this case, breast cancer, that can simply be dialed up for patients with appendix cancer or PNP. The other things that I showed you are years or decades away. Let's say years, hopefully not decades. But it'll be years before, if PIPEC becomes mainstream, it'll be years before that happens, I would expect. And same thing for Bromac. Immunotherapy, certainly, we're nowhere near. Although the same principles apply in the sense that these drugs, we don't have to necessarily invent the drugs because they've already been invented for breast cancer, lung cancer, colon cancer, whatever. But getting the momentum and the funding and the energy to run a trial in appendix cancer is very hard because of reasons you all know. It's rare. It's not on the pharmaceutical companies' top 10 list, unfortunately, and what they're going to get a margin or return on investment. So these are limitations to what can be done. But it's very helpful if the drugs are already there. If tocilizumab didn't exist, we wouldn't have that clinical trial. We can't invent the drug and in a rare disease and get it off the ground in a year. That would have taken a long, long time.
If we had CRS HIPEC several years ago, do we most likely have scar tissue that is formed, that is pocketing cancer cells, or not necessarily?
Not necessarily. Everybody's different. It happens for two reasons. Some people, even if they don't have cancer, if you operate on them, they form a lot of scar tissue. We don't really know necessarily why one person does and another person doesn't. Cancers, in some cancers more than others, especially signet cell cancers and goblet cell adenocarcinomas, they generate a lot of scar tissue around them molecularly. Whatever they're making or whatever they're secreting, it's just drawing in the fibrous tissue or the connective tissue, and it gets dense. And there's also inflammation involved too. Even if you don't have cancer, an inflammatory event or inflammation from mucin or something else can also create a lot of scar tissue. Fistulas do that a lot.
So if we do have adenocarcinoma with signet cell, will that necessarily show up on imaging at all? No.
It's notoriously inaccurate. Yeah.
Happened to me.
Yeah. Yeah, so I didn't talk about imaging, but I don't think that we have a lot on the near horizon for imaging. There's an endless debate about MRIs versus CAT scans. Neither one of them is all that great. So it's, hopefully one day we will be able to do something better than either of those two. But the same argument over MRI versus CAT scan has sort of gotten old. And I think there's just providers that are very used to looking at CAT scans like myself and others that have a radiologist that just loves to stare at MRIs, and then they have to tell you what's on it because they're very hard. They're very blurry for most of us to read. So I don't think I've seen anything on the immediate horizon for improving imaging for peritoneal disease. hopefully this isn't being recorded and sent to some of my colleagues who have very strong opinions on this. Yes.
My question is about the efforts that the surgical community is making to get the word out about PMP. Mark was cured 20 years ago. And back then, there were very, very few surgeons who knew how to cure a patient. There are many more now, and we're all grateful. But even so, in his case, and probably many of your cases, the local surgeon who finds it says, "Oh, I can take care of this." And our job is to say, no, I'm going to find one who's a superstar.
Yeah.
He can actually cure you like Mark got. And so I remember one doctor, he came from LA for a conference, and he was so angry that the lectern was shaking. And he was saying that it was his mission to get the word out about PMP so that a surgeon would do what we wished about March to do, which was to say, I took the sample, I sent it out, I zipped you up, go find somebody to do, instead of saying, oh, it's a couple of days in the hospital, a couple hours of surgery. He said, they're killing people. So my question is about the efforts that the knowledgeable appendix cancer surgical community is going to get the word out to all of the people who find the ovarian cysts and find the hernias and open somebody up and say, this is jelly, right?
Yeah.
To do the right thing and to send people to great surgeons rather than cracks.
Yeah. So I think I have a warped perspective because I walk in circles of those surgeons that dedicate themselves to this work, and also seeing patients that come either from, usually, hopefully they've been diagnosed and then immediately sent, but not always. So I think that education, certainly in the surgical oncology field, has improved quite a bit. I do think there's a lot of pressure from health systems to have programs, and this, if you want to see me shake a lectern, I'll make you do it. The pressure to have, the world does not need more high-tech programs, right? It just doesn't. And this is part of the problem, is that it does not help anyone to have a high-tech program that does 2 or 3 or whatever, 4 cases a year. And yet there are patients that don't have the means to travel. So it's always hard. You have to see both sides of that. If I'm a patient and I don't have what it takes to travel 1,000 miles to an expert, and there's a surgeon down the street who doesn't do it as often, but does know what it is, that's the dilemma, right? So we have to balance the need for patients to have access to care as close to home as possible with quality. And we haven't struck that right balance yet for many kinds of cancer. This is one example, but it's not the only example.
Yeah, I was also.
Yeah, I think. So I have been out in I've been in academic environments, I've been in community environments, and there are cowboys. Hopefully, that's a thing that is hopefully going away as time goes on. You have to be honest about what you know and what you don't know, and what's And I think good surgeons are. It's just that. Hopefully they know the limitations. But that wasn't the old mentality in surgery. That's hopefully a new but increasingly prevalent mentality that this just isn't what I do, and it's not the right thing to keep going.
Thank you. Thank you for being here.
Sure.
Could you speak to how you and your colleagues connect with that large cancer research community? Because there are centers of excellence. There's now 2 decades of immunological research. But 5 years since I've been diagnosed, it's hard for me to kind of see where you all connect. Imagine you go to conferences.
Yeah.
And if you can just speak frankly, we are used to being marginalized. We're used to being told maybe it's not even cancer,
right.
et cetera. I'm wondering what that's like for we know you well, we know all your colleagues. What's it like out there? Is there a bit of suspicion, and even amongst the research community?
Yeah, that's a really insightful question. So first of all, we get together a lot. We have our surg-onc meetings. We have our surgery meetings. Medical oncology meetings increasingly have sessions on they take it seriously now. I think peritoneal surface disease. I think some of the clinical trials that I didn't talk about here today, showing long-term outcomes, they can no longer be ignored or questioned. I think there's a big international community, not just in the U.S. but worldwide. And hopefully, as surgeons, we have passed beyond the stage of fascination with HIPEC to rigorous science. And I think the more of that we do, the more seriously the rest of the community takes it. It's hard to be taken seriously when you haven't done the studies, and it doesn't matter how many thousands of HIPECs that you've done if you haven't. The science isn't there, right? And so people get sort of tired of hearing about uncontrolled trials and then like commercials for HIPEC. It's just, for a long time, if I could do anything, go back in time to when HIPEC was invented, and just a couple of trials in the 80s would have set this all right, and unfortunately it's impossible to untangle it now because you have very strong opinions and decades of publicity and whatever. You can't put the genie back in the bottle. You can't randomize a person now to get HIPEC or not. That has to be a decision that has to be made. No one's going to flip a coin for that in this era, right? They're going to want to participate in that decision, and they should with their doctor, right? So I think the more science we've done, the more seriously the field is taken. And these days, I don't think we really back down from anybody in that regard. We have just as much research going on and just as much science involved in what we're doing. I do worry with some of the emerging technologies that the same thing could happen again. And so I hopefully it won't, but sometimes you take an idea and it's appealing and it should work, and it's really hard to just dial the enthusiasm down just a little bit until some structured trials are done, to be sure, or just to be thorough, right? Or just really to get the information. But if it's like sometimes it catches fire and it's impossible to get it back into a controlled situation because it just proliferates and there's no way to go back and do the work. And, it's almost like finding a jury for a high publicity, crime. Everybody's heard what's going on, and before you can even find 12 people that are neutral, everybody's already got an opinion, right? That's sort of what happens with some of these things. And so I think the more rigorous and disciplined we can stay with that, the more seriously things are taken.
Why it's happening here versus others?
Yeah. So the question is about, it's an epidemiology question. What's causing, is there an increase? If so, is it genetic? Is it environmental? I think there was a very important study that was published maybe 2 or 3 years ago now, looking at genetic predisposition to appendix cancer and finding a few genes that were associated. I don't have the details off the top of my head, but it was out of Vanderbilt, I believe. Mm-hmm. And that was the first time that a genetic predisposition was shown to appendix cancer. And that doesn't prove that it's genetic or environmental in any way. It's just there's going to be a genetic component to everything, and there's going to be an environmental component to everything. The problem with environment and rare cancers is that think about everything you've had to eat already today, right? And then every day of your life, and it's an impossibly complex, and that's just food, right? What about the air? What about the water? What about plastics? What about everything else? You can't, it's even with common cancers, it took forever to prove that smoking was related to lung cancer, which now seems like a no-brainer, right? But that was decades of science for that. And that's a huge, that's a very provable and a huge risk factor for a very common disease. Mm-hmm. So you can imagine what it would take in a rare cancer like appendix cancer to even find it. I probably can do one more and then I have to run back to the...
So I just wanted to say thanks for coming and sharing, your expertise with us. So what I'm hearing from you, for those of us living beyond diagnosis in the next 1 year, 5 year, 10 year, this serendipitous connection to currently FDA approved treatments for other cancers is really going to open the doorway to appendix cancer treatments for us to improve longevity. And a lot of that is going to be based on the genetic mutations associated with those more common cancers.
I could not have summarized my presentation better. We have no choice but to be opportunistic, right?
Okay.
We have to read about what's going on in every other cancer and just, can I apply this to appendix cancer or not? Does this puzzle piece fit or not? Most of them won't, but I think that's a very smart strategy.
So how do we advocate for ourselves for an off-label use?
So let's talk about that at dinner, because that's a long, well, I have to think about that. I'll be back. I'll come back for dinner. I just have to run over to that.